Hi, I'm Shoham, and I'm the Associate Director of Preclinical Curriculum here at Sackler School of Medicine in our New York American program. I'm sorry I can't be with you on your visit to Israel. I'm in your neck of the woods, working in Toronto. But I have prepared a few slides for you, and also my trusty right-hand woman, Shani Evanstein, is going to be here to answer all of the questions that you have about our wonderful preclinical curriculum. So without further ado, I'm going to move you over to a few of the slides that I've prepared, and we'll meet again at the end. So, as you can see in a moment, I've provided you with a sampling menu of some of the wonderful components of our program. Of course, I won't be able to tell you everything about everything, but perhaps your curiosity will be piqued, and then Shani can give you more details on the issues that you have questions about. I'm a proud graduate of McMaster University School of Medicine, few years ago, shall we say, and sooner or later you'll hear from my accent that I am Canadian. I also studied medical education at the Center for Medical Education at Dundee University. Shani will tell you more about herself when it's her turn up at that. In my position here at Sackler, I wear many hats, sometimes I think too many hats. But this is a little bit about what I do. Firstly, I'm in charge of curriculum development. I develop all of the materials for our courses that involve alternative forms of learning. So certainly I don't help our very, very competent and world-renowned scientists develop their PowerPoint presentations. But when it comes to some of these small group interactive learning exercises, I certainly am there developing the materials. On the other side of that coin is, of course, helping the faculty learn how to teach differently than they may have taught for sometimes decades, and that's always a challenge for all of us to learn something new. I'm also involved in all of the assessment tools that we have in our program, in our preclinical curriculum. We have a large series of quizzes and exercise that are formative assessment, and we use the National Board of Medical Examiners customized exam service in terms of our summative assessment. More about that later. We are continually evaluating all parts of our program. We really try and get our students involved in the micro and the macro evaluation of what's going on with their education. We take their comments seriously, and we integrate changes every year based on how our students have perceived the education that they have received in certain areas. One of my other roles is meeting with students on an individual basis in order to help those who are having difficulty or those who are just feeling that they need a new approach to learning. Some of them come, of course, very accomplished from undergraduate and sometimes even graduate degrees, and yet medical school presents a different series of learning strategies. And so we often do one-to-ones with students and refer them, of course, on to more professional educational and psychological counseling, of course, if need be. Very proud to be responsible for our peer tutoring program. One of the things that students often comment about when they're at Sackler is the sense of community, the sense of less competitiveness with their peers. And certainly we see this best in our peer tutoring program, where students at many different levels through the 4 years are helping junior students usually in a variety of ways, which I hope I'll have time to comment on more fully. So by now on your visit you may have met a lot of the people working here in our program, and I prepared this hierarchy, and I apologize if it's not accurate because we're in a state of flux at the moment in terms of some organizational changes in our program. But as you can see, our fearless leader at the top of everything is really in charge of the whole Faculty of Health Sciences, and under him we've got other faculty leaders particularly the head of the School of Medicine, and then the program directors for each of the 3 MD programs, something that's quite unique for a medical school, 3 separate curriculums for MD programs. So let me tell you briefly about how our new curriculum, which is not so new anymore, came into being. We're now in our 8th year of new curriculum, and we started with a mandate from the dean at the time, Professor Fanaro, and our program director, who some of you may know from your own studies here, Professor Louis Schenkman, a mandate that it was time for a change. There were many reasons for this, and I'll go into a few of them. So, but first of all, we have to identify, well, why change? What's the reason for it? We worked over 5 years in looking at other curriculums, looking at the needs of American students, and particularly IMG students, and came up with a proposal that was eventually implemented, approved by the Curricular Committee of the Faculty of Medicine here in Tel Aviv, and then implemented in 2008 for the first time. We had a struggle, a battle in cultural differences that you could see back to 1890. American and European medical people don't always see eye to eye or see things in the same light, but we managed to get over that, and we did create a new curriculum that took us out of the age, or at least on the way out of the age, of blackboards and frontal lectures and passive learning, into and from, as you can see, this is the former curriculum, a plan that could have been present in the 40s or 50s or even the 60s in the United States or Canada, a bunch of courses that sometimes might have gone together, but most of the time was just an odd, random set of lectures and labs that didn't necessarily hit the same even organ system at the same time. The second year might look a little bit better, but by the second year our students had kind of learned not to show up, sometimes not even at all, which created a great degree of anger, embarrassment, and lots of yelling in the hallways for sure. So we also needed to take into account the changes that are happening worldwide in the fact that this generation do not learn well in the lecture hall. In fact, the question has been raised, is the lecture dead? And so it hasn't quite been announced to be clinically dead, but it has received some kind of resuscitation in the form of various learning strategies and in the introduction of digitalization into the classroom. So, having identified all these problems, we also had to assess what the unique needs of our American IMG students were. We had information about the LCME and how they accredit medical schools, what they are looking for in the students that come out of programs that are accredited in North America. We also had the issue of the USMLE God, I call it, the Step 1 score that is so ultimately important, unfortunately, but realistically so, very important to our students when they're looking at being accepted to the residencies that have become very competitive. And so we also had to set up, given the problems and given the needs that our students have, what goals and objectives our program were going to identify. We had lots of help, lots of help. There have been so many position papers, so many works of art really in medical education over the last 10 to 20 years across the world, Europe, Canada, United States, all provided us with documents that we could use. And we also looked heavily at objectives from the American Association of Medical Colleges that stressed that medical school is not just the scientific knowledge. And the first 2 years of medical school are not just the preclinical basic science topics. There were many other goals that we had to be looking at if we were truly going to have a competitive curriculum. We talked about a competency model, and there are many different models and many different competencies. They cover the same things really, but I like these ones from Brown University. And it's not a typo that there's a space there, it's that I've just left out the basic science knowledge that we all, I'm sure, agree is paramount to any physician becoming a good physician. But there are so many other things that we have to take into consideration and look to see where we pinpoint the student is learning them in our curriculum. One of the main objectives that I took on for myself, and I come from a problem-based learning school, so that wasn't too difficult for me, was to look at the LCME's educational objective of self-directed learning and independent study being extremely important parameters in a modern medical education today. And as you saw from that brief list of subjects in the old curriculum, it wasn't necessarily happening here at Sackler. My goal, and when I like pictures, and you can see here that this is from Dalhousie University, and this is what I would like to see in the graduate of the New York program at Sackler. I'd like to see a professional, a community contributor, a skilled clinician, and someone who has the skills and we've given the tools to learn for the rest of his or her professional life. Tall order, but I think we're on our way to doing it. And so, as I mentioned, we're not just spoon-feeding a list of facts anymore. That appetizer is no longer just the memorization. And we need to think about which educational strategies are going to complement all of these lofty goals and objectives that I've mentioned so far. We looked at strategies and strategic models of education that aren't just for medical schools, but in general, but many medical schools did take on what we call the spiral curriculum. And the spiral curriculum looks at something that's not a model, a linear model, where, okay, semester 1, you learn it, you test it on it, you forget it, semester 2, same, ad nauseum, but rather taking tools on an entry level and then readdressing them in a more sophisticated level as the student moves through all years of the curriculum. And as I'm sure you're aware, today we're talking about a continuum of medical education. We're not talking about a division between preclinical and clinical so much, and we're not talking about a division between undergraduate and graduate education anymore. And so these are all skills, objectives, skills, knowledge, attitudes, behaviors that are going to serve the student from the first day of medical school, probably well past fellowship, until they're experienced professionals like ourselves. Okay, where are your cell phones? Check your pockets. I'm sure you've got one on you, and if you're don't have it, and you don't know where it is, I'm sure at this moment you're panicking. Well, that's how our students operate, of course. Without a smartphone, without their, usually their Mac laptops, they can't function. And we can't either. But they were born into this digital age. We are just kind of tourist visitors that have come on it at various stages in our life. We have to adapt our educational strategies to the way they learn, and they learn with devices. They don't learn by sitting in classrooms, listening passively to lectures. They have multiple modalities that they use, and each one of them may use a different combination of strategies and modalities that enhance their learning. So what did we do to take this into consideration? Well, I'm going to backtrack just slightly and show you what our curriculum looks like, just the skeleton of it, so you can have an idea when I talk about what we did to digitalize it. First year of the spiral curriculum is what we call the building blocks of basic science. No more semesters, trimesters. Each block is tuned to the subjects that compose it, and the subjects or disciplines that compose it we try and make them inherently ones that go together. So biochemistry and genetics is one example, systems, physiology, anatomy, embryology, and histology, where students in a given week would have the heart module or the chest module, the GI module, and be learning all the different components of the sub-disciplines concurrently. Okay? You can see these colorful little squares on the side, and these refer to what I call horizontal threads in the curriculum. These are threads that don't finish in one block or another, but sometimes run through the first 3 years of the curriculum, as in the case of our MPSD, Medicine, Person, Society, and Doctoring. This course is one in which every student is in a small group led by a physician, and the physician acts not only as a teacher, but as a mentor, role model. The student begins to learn his or her communication skills as a student physician in this course. The student also has his first clinical exposure in the community in first year in the confines of this course. It's a very, very important one. You also see the little blue case-based learning, and this is where we start to incorporate the digitalization in our curriculum. First of all, I have to say that everything in our curriculum from day one of medical school has a clinical context associated with it. And that's a big change from the old-fashioned curriculums where basic science was learned to learn basic science, and they'd worry about that clinical stuff later, is the phrase we often heard. In our case-based learning, students, again, work in small groups to solve clinically contexted questions that help them learn the basic science that is the underpinning in the first year. Talked a little bit about the peer tutoring program, and even in first year we have second year students mentoring our first year students. We have second year students leading learning strategy sessions for each block. We have students leading NBME exam review sessions, and we have one-to-one subject tutors from third and second year helping out students who are running into academic difficulty in specific subjects. In second year, we move up in the spiral, and students readdress some of the same topics they learned in first year, again reorganized within the context of human systems and with a focus on the 3 Ps of second year, pathology, pathophysiology, and pharmacology. As you can see, each system has about 3 weeks devoted to it, sometimes a little bit more. You can see the MPSD thread running through, you can see the CBL, case-based learning, and you can see a few other things happening through the year. Pharmacology seminar, USMLE Step 1 prep course, which is part of the peer tutoring program, a nutrition elective that again is system-based and helps to incorporate nutrition learning objectives according to the system the student is studying at that time. And you see for the first time the clinical days. Our students going out to the hospitals for the first time and meeting with patients and starting to practice their history taking and physical examination skills that are appropriate for the system that they are studying at that time. You can see that we give an 8-week period at the end of second year where students prepare for the NBME comprehensive exam, and then subsequently following that for the Step 1 exam. This is just a screenshot, and don't even try to read the small print because Shani will be able to show you this a lot better later. But you can see that in first year, there's still a lot of scheduled time. But when you see the nitty-gritty of this, you can see that about half of it is lecture time and half of it is case-based learning, the small group learning that I just discussed with you. When you see second year, you start to see a lot more open spaces, a lot more study days, a lot more of the clinical days, okay, and grouping of lectures on days when students are here on campus for their mandatory CBL exercises. Okay, so I keep on showing you this slide of the empty classroom, and I'm mentioning the ways that I think that we're going to fill it again. Some of those are the CBL exercises that I've talked about, and part of that CBL exercise is the flipping of the classroom concept. So it's not just that we make them come to class for the small group work in the CBL, but we also help engineer the time out of the classroom by giving them online multiple choice exercises they must do in a timely fashion before the in-class sessions that they have to come to. Shani will show you a lot more about Moodle, our university platform, in which all coursework is uploaded for students, and that is actually the course center. The case-based learning that they have is again, a hybrid model of problem-based learning and team-based learning. Really don't have time to get into all the logistics of it, but we can answer more about that if you're interested later. And so our main course, okay, how the students learn and what they learn, is really a menu. It's a number of different learning activities that we help our course coordinators and our lecturers manage. What will go in? What will be the spice? What will be the dominant taste? Will it be lecture? Will it be CBL? Will it be more in-class lab time or less? Will it be a series of small quizzes? Will it be a larger one? And how do we go about deciding on that? It's with a lot of discussion. So our empty classroom has indeed become a classroom in which you see our students here in room 201 using their laptops, and they are Apple fans, I must say. You see students during the CBL exercise conferring with the facilitator. You see our students working in small groups scattered around the floor, since we don't have a lot of small group classrooms. You see them talking with each other. You see them using the computers, looking things up. No more textbooks, it seems. You see them using other high-tech study aids, such as clickers, or we now use the cell phone as a clicker. Many different modalities. I mentioned the peer tutoring program and its many different facets. This is the certificate that students get at the end of fourth year. We award them at the graduation ceremony, and this year there were so many peer tutors that we couldn't even have them come up on stage, but we just had them stand. And it really, really has blossomed into a wonderful program that I'm quite proud of, if you hadn't noticed. And so, is it working? Are we doing our job? Are the students doing their job? Do we have to change anything? Well, these are the questions that we ask ourselves constantly, and certainly one of the tools that we use to see if we are on the right track is the scores on the National Board of Medical Examiners final examinations that students write from the very first block of first year. Every block and every system ends with an NBME exam. This is part of the customized exam service of which we were in the pilot program. Here you see just how our instructors, be they Professor Kisari or Shai Israeli, famous immunologists here in Israel, have chosen questions from the NBME bank that fit the learning objectives in the syllabus that they've created for the course. So we don't have any more randomized banks of questions that may or may not hit what the students were learning here. We have a very fit exam that hits all the learning objectives. Dessert, always my favorite part of the meal. And the pièce de résistance in this new curriculum is the fact that since its implementation in 2008, our Step 1 scores have been constantly on the rise, and there's a statistically significant improvement. This year, I'm proud to say that our average score was 230, and we have some really highball, out-of-the-park scores that, of course, the students are very, very proud of. Needless to say, and you know a lot about this more than I do, those scores are often paramount in getting these students wonderful residencies, even these days of horrible competition. So in conclusion, I'm going to share with you the questions that we continually ask ourselves. Who is the student physician that we graduate? What do they know? What do they like? How are they going to be as professionals? What's our part in creating that professional? What courses should we offer? How should we build them? How should we modify the structure of our program in order to produce the graduate that we want and that the market needs? I hate to use that word, but it's true. What learning methods are best? How can we mix it up so that every learner gets what he or she best needs to maximize performance? structure I've talked about, and we're continually asking what changes we should be making. How are we going to evaluate our student success? Is it just step one that's important? Does it matter? Or are there other parameters that we're using in our MPSD courses, in our role-playing, in our standardized patient model that I haven't talked about, to see who this is that's leading Sackler and going to be a physician in the States? And the penultimate question, what next? I think people are afraid to hear what next because it always involves change, and change is always difficult. But without change, of course, we would just stagnate. So thank you very much for listening. Here I am again, and I just want to say a final goodbye while I'm freezing in Toronto. I wish I would have had the chance to meet you and answer your questions in person, but Shani is here, and Shani knows every innuendo of our program. And if you do have individual questions for me, please feel free to email me. I'm pretty well available 24/7 and would be happy to hear from you. Bye-bye.